A 36-year-old female presented with pain and vomiting since 4 days. Two episodes of bilious vomiting was present daily. In view of the vomiting and pain abdomen, she was unable to take anything orally. She also gave history of undergoing appendectomy 4 months back, and she had undergone two cesarean section twice in the past. Per abdominal examination revealed a distension of the lower part of the abdomen. There was a appendectomy scar was present perpendicular to the right spino-umbilical line. At the McBurney's point, phalangeal incisions were seen in the lower part of the abdomen. Umbilicus was centrally situated. Patient was started on IV fluids and analgesics along with antibiotics. Investigations revealed the counts were raised to 13,560. X-ray abdomen revealed erect abdominal X-ray revealed air fluid levels in the central abdomen and the lower part of the abdomen. In view of the increasing vomitus and the pain, acute intestinal obstruction was suspected, and diagnostic laparoscopy was planned. A subumbilical 10 port was introduced, and it revealed a band arising from the terminal ileum and going to the anterior abdominal wall. This band, along with this band, there were omental adhesions to the phalangeal incision also. A second port, 10 port, was introduced in the right hypochondrium, and a 5 port was introduced in the left hypochondrium. The camera port was shifted to the right hypochondrial port, and the dissection was done through the left lumbar and the subumbilical port. The band was released from the anterior abdominal wall. At the base of the band, the adjacent bowels were adherent firmly to one another at one point. This was identified, and the adhesions were released with cold scissors. It was also seen that the bowel had herniated. The collapsed bowel had herniated from one side to the other side below the adherent bowel. The adjacent bowels, which were adherent very firmly, were released with cold scissors without using any diathermy. The raw surface was cleaned, and oozing was stopped with the wet gauze. On releasing the band and the adherent bowel, the peristaltic movements were noted in the bowel, and also the hyperemia of the bowel, localized hyperemia of the bowel disappeared. Omentum was seen adherent to the phalangeal scar. This was the omentum was held with the forceps, and the adhesions to the anterior abdominal wall to the phalangeal scar were released using diathermy. Hemostasis was achieved by using diathermy. This is not the complete. This is not the complete. Band is the band. The serosanguinous fluid which was collected in the pelvis was aspirated. Small omental bleeds which were present were after achieving complete hemostasis. Drain was Rayleigh's tube drain was kept in the pelvis. The ports were closed after removing the trocars. The patient is recovering well in the post-operative period. The Rayleigh's tube was removed on the next post-operative day along with the Foley's catheter. Patient was mobilized. Sips of oral fluids were allowed on the first post-operative day, and patient is recovering very well in the post-operative period. Thank you.